Yeah, this one I'm going to give you the lobe. This is from upper lobe.
Yeah, don't care.
now that now that we have lots of discussion on the lobe specificity or centricity, so now I want to give you some more information. This is from upper lobe, and we have a surgical lung biopsy. So this is a bigger biopsy than transbronchial cryobiopsies. Obviously, you can
Yes.
see you have the central areas, peripheral areas, the pleura, and everything, and the tips of the biopsies are also present,
Yes.
if that is relevant.
So, Raghav, can I ask you 1 second? I'm not going to ask you about any clinical thing. Okay, let's do pure pathology. Is this the only lobe, or are there other lobe biopsies coming?
We do upper lobe, middle lobe, and lower, all three lobes. We
So
do
you
have
have the
all.
other two to show?
Yes,
Okay,
yes.
just 1 second. And then the other thing I want to mention is, let's just take a little poll between the three of us, right? Raghav, can you take it to the lowest possible mag? Just the scanning, like go out even more. So between the three of us, guys, let's say UIP or not UIP based on this picture.
Not UIP.
Matt?
Not UIP.
Not UIP. Look, complete consensus between three pathologists. Absolutely not UIP, right? This is almost diffuse. Actually, this brings up a very interesting point about NSIP that people ask. They say, and it comes up once in a while, is how much spared lung can you have? You know, how diffuse does it need to be? Can you have a little bit of spared lung? And usually, at least I think that you really shouldn't have much spared lung, but a little bit of variation in thickening is acceptable. So like here in the subpleural areas, it gets slightly less, and then on the other side again slightly less, but slightly more in the middle. I think that's acceptable as long as it's fairly diffuse. There's no scarring, no honeycomb change. So Raghav, do you agree with that interpretation? No
I
scarring, no honeycomb
I do agree with that interpretation, that it does have a NSIP kind of look here.
at low mag. Yeah.
Yes, at low mag,
Yeah.
and there is no architectural distortion, means scarring or honeycomb changes.
Yes. So, I mean, what I'm trying to get at, I'm not saying this is NSIP. I'm just saying at so far it is not UIP. And all three of us would agree. Hopefully, you also agree, Raghav, not UIP in this field, right?
I did agree when I first looked at this slide.
Yes. Yeah. Okay. Let's see what comes with the others.
So let me show you the same low mag of the middle lobe and lower lobe
Yes,
also.
that's why I asked.
Sorry, one question for you. This right side is not destructuration. It's not. I mean, like in the small piece, there is the right side has somehow lost its structure a little bit.
Yes, yeah, that's a good question, Irene. So you're asking, is that scarring or not, or architectural distortion? This is
I would be doubtful.
Yes, it's doubtful. I don't think it's completely lost yet, the architecture. So I think this is still within the realm of, fairly maintained lung architecture. So at least what's going through my head right now is this some sort of a CTD-ILD with all these lymphoid follicles and germinal centers? Or is the whole thing SRIF? Or third, is this a UIP in which he's only showing us the one part of the thing and the other lobes have clear-cut UIP? That's what's going through my head at this Mac, without knowing anything else.
I think those are perfect differential diagnosis, Sanjay. This is a middle lobe.
Yeah.
Now we are in the middle lobe. So any thoughts? So you are missing some honeycomb changes, right? What about now?
Now I think you have a little. Now I can't see much at this low mag, but right in the middle of the upper piece, there's an area that has at least microscopic honeycombing. Yeah, there. And again, Irene mentioned, there's a little bit of scarring, like it was in the previous one, and there's a fibroblast focus in the bottom of the largest honeycomb cyst. Yeah, there's a fibroblast focus there. So things are beginning to get hot and interesting.
Yes.
For me, this is structured. I would call this one UIP.
Yeah.
Yeah, it's getting there. And you've got some normal lung on the right side, right? So
yes.
There's some...
and the other in the other piece there was also normal lung, I saw.
Yeah, this is the middle lobe and the normal lung. Yes, there is some normal lung here, right here.
A lot of normal lung, right?
Yes.
I mean, Raghav, on the right side, it's almost completely fibrotic, and on this side there's almost a. And are there smokers macrophages in there, Raghav, in that lung that you were just showing us? Just show us the alveolated normal lung on the left side.
Yeah, there are
There-
macrophages.
Okay, just checking to see what else is in there.
There are macrophages, and yeah, the famous pigmented macrophages are present.
Okay.
Now we are in the lower lobe. I have two slides of this lower lobe. So this is one.
This is a very good case because it really shows you the challenge of these cases and how you could.
More of honeycomb changes, more of lymphoid aggregates.
I want to hear the what Matt and Irene think first before I say something, because
Let me show you one more, and then
Yes,
we
yes.
can take their.
yes, and I'll tell you one more thing that happens in these. When you have multiple people looking at the same thing, sometimes what the first person says influences the other people, right?
Oh
So
yes.
you do
Oh
not
yes.
want to
That's,
say, "Hey, not at all. You're just talking crap," because something happens is the first person what they say might be completely opposite to what you think, but you think, oh my god, if he's saying this is a classic NSIP and I think it's UIP, it'll look, there's conflict. it looks like there's a problem, right?
I have an idea. Why don't we all write down on a piece of paper what we think our diagnosis is,
I love
and
that.
then we can show it up to the camera,
Let's do that.
and then
I
that
have
way.
to look for one.
Should I be writing, because I know the diagnosis?
You should
Well,
be writing too,
You
Raghav.
should write yours too, right? That way you can't change.
I can't change. Okay.
But can you show us what you were going to show us in the last piece, Raghav?
This is the fourth one. This is the last one. This is the last one.
That's a great idea, man. Have us commit. Can you, Raghav, can you show us the middle lobe thing one more time before I put my thing down on this?
So that's the middle lobe. So we have two pieces here. One of the pieces has got this honeycomb changes here, the peripheral fibrosis, the subpleural fibrosis.
You don't. I think your description is biasing us. But how about the one below? No, the other piece, Raghav?
Yeah, yeah. Oh, yeah. I should not bias, right? Yeah, that's right. You just mentioned that.
Okay. I think I'm yeah. How about you two? Ready?
No.
Yeah, you can. Don't write the comment here.
Don't have to write the comment.
Okay.
Right. Okay, who's going first?
Since this is my idea, I'll go first.
Okay.
Okay.
Let's see your thing, man. Hold it up to the. You'll have to.
So I said UIP with possible
UIP.
possible CTILD.
CTILD.
Yeah.
With what?
Connective tissue disease related ILD.
Okay.
UIP, CTD-ILD.
Nice.
Irene?
The same.
We should not have a consensus like this.
What did you say? UIP, smoking, and what did you say below that?
Come and look for CVD. I call it CVD, collagen vascular disease.
Very difficult, but favor UIP.
So we have consensus in 4 pulmonary pathologists.
Man. That's not bad. Actually, my guess is if you showed it to 4 other lung pathologists without telling them all this discussion, you would get a lot of different interpretations on this case.
Can I ask a question? What do people think about a combined NSIP and UIP diagnosis, or like overlap? Or I sometimes see cases that are called that, and I won't bias you with what I think of that, but given this appearance in the one lobe, calling this NSIP and the other one's UIP.
Let me hear it from these guys first.
I think that this is maybe SRIF, this upper lobe. I saw the fibrosis and the macrophages. Maybe it's not NSIP in this one. I know it's diffuse, but as we have seen the other parts, I like the collagen and the macrophages. Maybe it's this combined.
But Irene, let's say this was classic NSIP, right? Let's
Let's
say it
say
was
that
like this. What would you do if it's UIP in one lobe and NSIP in another lobe? What do you do?
I would, if there is, preserved lung, normal lung, I would call it UIP, because as NSIP, I think I can find NSIP like areas in UIP cases. But if it changes a lot, I would maybe go just descriptive and say it's non-classifiable. And with the follicles, it's good for collagen vascular. Maybe sometimes they have not a good pattern or not a classic pattern or mixed.
Raghav, what would you do? What do you do if there's UIP in one lobe and NSIP in another?
Yeah, so since this book says that focal NSIP is allowed in UIP, so I would still favor UIP. That's easy for me. But I like Irene was making a good point that some of the background stuff could be because of smoking related.
Yes, I actually agree with that. So Matt, I know you will challenge me on this, but I think the
Agree.
that part which we were looking at, another thing about SRIF, I think we haven't mentioned enough, is that Raghav, if you can go back to that spot where Irene was saying that it looks like SRIF. Yeah, it's on that side. So just stop it there. There's another thing about SRIF is that these spaces look boxy. They look like rigid.
Yeah,
They look rigid spaces.
yeah.
So what happens is the emphysematous lung, because the walls are now uniformly thickened, each emphysematous space looks like not a rectangle but rigid. There's that rigid, and I think that's very good for SRIF. Now, one interesting thing, when you guys have brought up the CTD-ILD, I know because of the lymphoid follicles and the germinal centers, but I'll tell you one interesting historical fact, okay? So historically, when Libo described the DIP thing, one of the features that they had described was lymphoid follicles in DIP cases. And interestingly, you also get lymphoid follicles in SRIF once in a while. So you have here and there, scattered lymphoid follicles. In fact, if you look at Carrington's paper from 1978, they actually mention that some sparse interstitial infiltrate is necessary for a diagnosis of DIP. So I think what they're bringing up is in these smoking-related interstitial fibrosis cases, or what I would now call SRIF, it's not unusual to have occasional lymphoid follicles and germinal centers. Now, I acknowledge this case has a lot. I mean, there's so many, you can see it at low mag. So it's certainly reasonable to think about a CTD-ILD, but I'm actually more in line with Irene's suggestion that at least some of that fibrosis is SRIF, it's not NSIP. And then the second issue is of the UIP NSIP thing, Matt, that you asked about. So I use UIP as the trump card. If there's UIP in any lobe, I call it UIP, and that's because of two studies. One was by Dr. Katzenstein, which she did with University of Pennsylvania people, where she looked at explant, pneumonectomies, where she showed that cases of classic IPF transplanted for IPF and with UIP often have NSIP in other lobes and it makes no difference. And another is an old study by Flaherty et al., where they looked at, UIP, NSIP discordance cases, and they all behave like UIP. So the prognosis is always like UIP. So it's a bit like, in my mind, the concept is, if you have a adenocarcinoma in one lobe and a granuloma in another one, is that malignant or benign? That's how I look at it.
I agree.
Yeah.
No, that's a good analogy. I completely agree with that. So even if there's some areas with NSIP, I still take the UIP thing, because for me, as a lung pathologist in the non-neoplastic world, the most important job is to recognize UIP. That's what I feel about this job. So if
Okay,
you
can I ask one more question to you guys? Because this is a very interesting point to bring up. This is about lymphoid follicles and CTD-ILD, right? I want to ask you guys how you practice. Let's say a case is just beautiful CTD-ILD. It has NSIP everywhere. There's no UIP. There's lots of lymphoid follicles. And you're saying, man, this has got to be CTD-ILD. What do you say in your top line diagnosis? Matt and Irene?
NSIP. We look comment in the comment. The presence of lymphoid follicles in pleura bronchioles, whatever, makes rise the possibility of
CTD-ILD.
CVAD.
And what happens then if you don't have a CTD-ILD by serology and clinical features and all that?
Nothing, because
There is not,
I
there is
just
no,
said NSIP.
yes, so
It
I'm
must be
asking you,
nothing.
Irene, so in a patient who you think has CTD-ILD but does not have a CTD-ILD, what do you think is going on? Is that still a CTD-ILD or not a CTD-ILD?
I think some things are not that easy to, maybe it's not a rheumatoid arthritis or so, but
Has a
my
flavor, has a flavor of CTD-ILD, maybe.
maybe,
Yeah.
or
That's what people call IPAF nowadays, right? People call that IPAF is a case that does not have a CTD. That means they went to a rheumatologist and the rheumatologist said, no, that's not a CTD-ILD. So they said, how dare he? I'm a pulmonologist and I feel that the patient has joint pain and the ANA is slightly increased. How dare they say that's not a CTD-ILD? We'll give it our own name, and the name they gave is IPAF, interstitial pneumonia with autoimmune features, which I like to call flavor, autoimmune flavor, right? So some people,
No.
I want to ask Matt first before I kind of editorialize on this. So Matt, what do you do? Let's say you have a classic CTD-ILD on biopsy. How do you top line it?
I still don't put that in my top line. That's
Yeah.
me. It comes up
You
in
can
a
never
comment.
fail with a description, right? With I think many lung pathologists have figured this out.
Yeah, you just put in the comments.
Let me ask you then the same question. What if the patient then doesn't have a CTD on serology and all that? What do you think is going on then? Is that a CTD-ILD or not?
It's not, and I think these are non-specific features. I think you can see them in other things, right? Some patients who have some of the familial types of interstitial lung disease, including shortened telomeres, can have more lymphocytes and things like that. So it's not. I don't think it's a feature, but it's not diagnostic of that. I think it's a clue, but not a definitive diagnosis that it has to be a CTLD.
Correct. And I think I'll just this is really the crux of the problem. The crux of the problem is that people have different views about what happens if something has a so-called CTD histology but no CTD. And there are like the CTD fanatics who say, no, this is still a CTD because we called it a CTD and this has classic CTD features. There are other people who say this is IPAF because it doesn't have a classic. And there are other people who say, well, if there is nothing clinically to support that diagnosis, it's idiopathic. It's we don't know it's still an SIP, but it doesn't have a classic CTD. So Raghav, how do you see this whole problem?
Yeah, means I think you guys hit the problem right away. So in this patient, the rheumatology consult was negative for CTD. So it was negative. They could not find anything suggestion of CTD. And then the other problem Matt was mentioning was the patient had a family history where two of his relatives had some unspecified respiratory disease. And then there was a suggestion of genetic testing was told to the patient, but they could never get it because of some issues. So the point about this problem is you have what you think is features of CTD, but like you mentioned, like Matt was mentioning, I don't top line that in my diagnosis mentioning CTD. I just mentioned that in the comment. In the top line, I would say that this describe this inflammation, lymphoid aggregates, and in the comment section, I do say that if the CTD serologies are negative, and then it could well represent IPAF autoimmune features. I do mention that. I've been starting mentioning that because to answer this problem where the CTD workup is negative, and then clinically they don't think it's CTD.
Right. Yeah. So there are three flavors of this, right? One is classic CTD, patient has CTD, fine.
Yeah.
That's
Yeah.
it. Classic CTD, patient doesn't have a CTD, but they have flavor, the joint hurts a little bit, there's a little bit of ANA, some other serology is slightly positive, where a rheumatologist would say, well, this happens all the time in patients who don't have CTDs, but the pulmonologist insists. And the third situation is no sign of anything, right? There's not even the slightest sign that the patient has CTD, but the histology is still, so-called CTD histology. So we have to I think there's no way to solve this because everybody has a different concept in their mind
Yeah.
of what that might be. And just as briefly, Raghav, about your thing about the patient has two relatives with non-specific respiratory disease. I have two relatives with non-specific respiratory disease. I bet Irene and Matt have two relatives with non-specific respiratory disease
Yeah.
too. I what does that mean to have?
Yeah.
What does that mean if even if a patient has a relative who has cystic fibrosis or something else? I think the only time that actually means something is if you have a strong family history of IPF or some sort of pulmonary fibrosis. Then you can say that there is a genetic thing going on, or maybe you tested for telomerase, or you found TERT mutations in the family. Then it makes some sense. But otherwise, I feel the genetic thing is also pushed too far sometimes. We accept too many things as possibly genetically related.
I think it also depends on the demographics of the patient, right? If this is a 40-something-year-old patient with what looks like UIP, I think that that's another clue that this is not your standard UIP, in a 65-year-old male, right? That would be another clue that there's
Yes.
potentially a familial component.
Irene, thoughts?
Somebody has to tell this patient to stop smoking.
Yes. Is it a smoker, Raghav? Did you find out?
Yes, he is a smoker, and so to give you specifically, yeah, he had been smoking since years and years and years. So obviously, he was in a construction job, but otherwise he was a heavy smoker, and now there was no connective tissue disease. And then they asked him to stop smoking, and now the symptoms are much better.
So Raghav, can you just bring it back to those smokers macrophages for 1 second?
Yes.
Yes. Matt, do you like that for DIP now? It's full of the airspaces are full of macrophages, and there's a
No,
lot, right? No.
I wouldn't call this DIP. I would just say there's lightly pigmented alveolar macrophages, because I think there's there's a UIP going on here, right?
Yes.
And that this is a risk factor for UIP.
Yeah. No, I'm only kidding, but the term. One of my biggest problems with DIP is, if you really need a term to describe lots of macrophages, then desquamative is the worst possible term you can come up with.
Oh, probably.
Right? Yeah, okay. I'll leave it at that.
So, question to everyone. So, do you guys use molecular classifiers to support the diagnosis of UIP? Because I've seen some recent papers coming out. They've been using this molecular classifiers, especially in transbronchial cryobiopsies.
Yes, I have two thoughts about that, Raghav. One is when pathologists keep on telling clinicians we can't agree with each other, one person's UIP is another person's NSIP. We keep changing our mind. We don't make a diagnosis. Eventually, what happens is they say, just get rid of these guys. They never make a diagnosis. Let's just send it to a better thing, which is molecular classifier. Is it really better? If you read the papers, it's horrible. I mean, the sensitivity and specificity both are really low. Like if a pathologist had that kind of sensitivity and specificity, they would be sued and thrown out of their department. But for a molecular classifier, somehow that is acceptable. And interestingly, I'll tell you just one anecdote before I stop. Is we have seen a molecular classifier case being sent out, and the molecular classifier comes back UIP, and the patient has an adenocarcinoma. So that's the accuracy of this molecular classifier for tissue diagnosis. I just do not have any faith in this molecular classifier. Irene and Matt?
We are not using these things. I've read a little bit also. I think it's with non-neoplastic lung is happening the same as happened with neoplastic lung. I think we thought, or some people told us, that our job is going to be finished because one molecule would change everything. But I have some faith. I would like that with a blood test the patient is diagnosed and cancer disappears. But I don't think that is going to happen. Just like hasn't happened in neoplastic lung, that it's far more easy than non-neoplastic lung.
Great points.
I think the chances of this actually working are low, given that this is such a heterogeneous disease, right? Can you imagine taking a small biopsy of random spots in this and grinding it all up and putting it into a sequencer and getting something when it's such a heterogeneous disease. If you take a gene expression picture of dense fibrosis versus a fibroblastic focus versus normal lung, you're going to get completely distinct gene expression signatures. But I do think there's a role for pathologists having a role in this molecular classifiers, combining both tissue-based analysis with gene expression changes. And I think there's technologies coming out to do that. And I think that will allow us to better classify these and to better understand the underlying etiology, because I think that is the next step for these, and not just saying that these are UIP, but what's driving it, and to get at those drivers is a way to better treat it. And I think if we as pathologists engage on that, we'll be the ones leading that. And I think that's an important role for us in going forward.
As we do with neoplastic lung.
Exactly.
Yes.
I think great discussion. Yeah, that's great. Yeah, we don't do any molecular classifiers or anything of that sort. There was a suggestion in this case, but otherwise it was not done, and I'm not aware of anybody bringing anything into our department. So that's what I can say, and I agree with all the points made on the molecular classifier, that it just looks like we have a like this molecular testing for an unknown primary kind of thing. So it gives you a number for like ovarian primary or a pancreatic primary, but in real, sometimes it's so like completely opposite of that. You find a mass somewhere else, and now the patient has got a different primary than what your molecularly classified ID comes back.
Yes. And that's the problem, is that the theory is actually exactly as Matt described. The theory is we want to all be a big happy family and incorporate molecular and advance the science. The practical thing is it's a horrible mess. Same as artificial intelligence. The theory is everything will be great and computers will come in. The reality is, when you call a telephone center, have you ever had a automated service answer your telephone? That's the reality.
Yeah,
that's true.
Yeah.
Such an skeptic. your lack of faith is.
All right, Raghav, great case. So just to finish the case, Raghav, can you just summarize for us what was your pathologic diagnosis, and at the end, what was the clinical diagnosis, and combining everything?
Yeah, the pathologic diagnosis, we did say that it's a UIP pattern with, I made a description of this interstitial lymphoid aggregates with germinal centers, and we raised the concern for a connective tissue disease related interstitial lung disease, even though there were some areas which looked like NSIP, but since there was also smoker's macrophages, and some of those areas did have some ropey kind of quality to the collagen. So we did notice that in the comments, saying that background, especially in the upper lobe, this might be because of smoking related fibrosis. And then that's where we let it off the report. And then later on, I learned that the patient was negative for connective tissue disease workup. And now I think the patient is cut down on the smoking and is still alive, and is able to do his work.
Okay. So did they make an IPAF diagnosis at the end of the day, or no? They just left it at UIP?
In MDD, we did come to that diagnosis, IPAF. That was in MDD.
Right.
So,
but it wasn't called IPF at the end of the day, or no?
No, it was not called IPF because there was an alternate signs of alternative diagnosis according to the guidelines of ATS, CRS. Again, that's another big talk.
We'll leave that for another session later.
Yeah.
Okay, so, thank you very much, Raghav. Great case. Thank you for sharing it with us.
Absolutely, my pleasure.